Good afternoon, everyone. Today I would like to present the case. Patient identity Miss Divya, 20 years female. She is unmarried, resident of Hyderabad, Hindu by religion, class 10 pass, and now pursuing first year degree college. And date of admission in NIMS hospital 20 days back. Informant grandmother and herself, which is reliable. She presented with chief complaints of generalized swelling in the body for 1 month, fever for 1 month, vomiting and decreased appetite since 2 weeks, and decreased urine output since 1 week. I would like to date my history since 2020, as the patient was apparently well before 2020. In February or March of 2020, she complains of the following symptoms of fever, which was intermittent, low grade, and non-documented, associated with joint pains, which included both large joints like knee and elbow and small joints like small fingers of the hand, and it was relieved on antipyretics, and there was no history of any evening rise of temperature or chills, rigors, cough, expectoration or burning micturations. She also complained of generalized body swelling. It was insidious in onset. Initially it was started in the periorbital edema, periorbital swelling, then gradually descended in the limbs, upper limb and the lower limbs. It was symmetric, and there was no history of any redness or swelling of any of the limbs, and also there was no she also complains of abdominal distension, insidious in onset, gradually progressive, and no history of any abdominal pain, swelling or vomiting or loose stools. During that time she had also exertion shortness of breath, which was increased on less than ordinary activities of day on climbing stairs, and also there was easy fatigability, and in that time she also complained of hair loss. However, there was no history of any oral or mouth ulcers or redness or any net-like lesions in anywhere in the body or anywhere in the body. During that time only she also had decreased urine output, and since the last few days, and there was no history of any burning micturation, red color urine, or any history of any frothy urine or increased urination at night, and also no history of any headache, skin rash, oral ulcer or easy bruisability. With these complaints she visited multiple private practitioners, and where she was advised local tablet medications, and no further investigations were done. So she was admitted in October of 2020 in Osmania Hospital, and due to where she remembers of having given nasal oxygen by nasal catheter cannula, and COVID was done on admission, which was negative because she admitted in COVID pandemic time. And she also remembers of receiving 2-unit red blood transfusion, PRBC transfusion, and she can recall receiving a costly injection called albumin, that she told 3 to 4 bottles of albumin she received. And she also underwent total complete blood and 24-hour urine collection examination and an upper GI endoscopy test also. Following this, she remembers to have undergone renal biopsy, and the doctors told her that she had some renal disorder where she is losing protein via the urine, and she was started on a tablet. However, she didn't receive any injections or as such. Following this, she was discharged after 20 days of hospital stay, and she remembers that she was started on a costly tablet called MMF because she had to buy that from outside, but she was not advised of any 2 weekly injections. She remembers of having a eye examination done also at this time. Post-discharge, she was doing well with the treatment. Her complaints reduced, and she was on outpatient follow-up. After 7 to 8 months of discharge, she complains of sudden onset chest pain, which was acute onset and in the entire precordium area, not associated with sweating or palpitation, but it was increased on breathing and coughing, and she was taken to Mahavir Hospital with these complaints, and she was taken in ICU, and she underwent echocardiography examination. She underwent, and she told, however, no invasive cardiac examination was done at that time, and she was started on cardiac medications. She stayed there for 7 days, and at this time she recalls that she was stopped on MMF tablets. 3 months she was stopped. As per her, the doctors had stopped MMF tablets because she was told that she has some cardiac problems only. This is on October 2021. Following this 3-4 months, she was doing well and she was compliant on the cardiac treatment. And after 4 months, she again she had sudden onset of loss of speech and slurring of speech. However, there was no history on any injury to the head, any vomiting, any facial deviation, or any difficulty in eye movements. She was taken to NIMS emergency, where MRI brain was done, and she was told to have some blockage or clots in the brain, and she was started on some blood thinners. From there, she was shifted to nephro department also, where she was told to receive, she remembers receiving some injections, and she was advised to receive 2 weekly injections every 2 weeks. But she was non-compliant and she only took 2 doses. This was in October 2021. Following that 2 years, she was doing well. She had no other complaints. She regained her appetite, and her urine output also improved, and till July of 2023. Now she complains of again similar complaints of fever, which was low grade, intermittent, daily, non-documented, and it was relieved on local antipyretics. It was associated with joint pains involving both large joints like elbow, knee, and also small joints of fingers. And there was no history of any headache, cough, pain abdomen, loose stool, burning micturition, chills, rigors, or evening rise of temperature. She also complains of generalized swelling of the body, insidious onset, gradually progressive, initially in the periorbital region, then in the both limbs, upper and lower limbs symmetrically, and also in the abdomen. And there was no history of any chest pain, palpitation, or shortness of breath as such. She complains of vomiting, that is multiple episodes, initially 2 to 3 episodes per day, and then increased to at least 7 to 8 episodes since the last 2 over the period of 2 weeks. It was not associated with any severe abdominal pain or any bilious or greenish amount of vomiting. She also had decreased urine output since the last 7 days. Patient contributes this to the decreased intake she was telling due to vomiting. However, there was on questioning, there was no history of any frothical urine or increased micturition at night, or any burning micturition. During this time, on asking, she complains of easy fatigability, as she has also dropped from her college at this time, and there was however no history of any hair loss during this time, oral ulcer, or any raised skin lesion, or any red network like lesion in the body. No history of headache, abnormal body movements, loss of sensorium, irrelevant talks. No history of any gritty eyes or chest pain, palpitation, cough expectorations, and no history of any taking long-term or indigenous medications. No history of any purulent nasal discharge or tingling numbness of fins or any blackish discoloration over the fingers. With this complaint, she was admitted in NIMS, and course in the hospital is that after admission, she recollects of receiving 2-unit PRVC transfusion, and she was taken for hemodialysis with a right neck catheter placement, and she was kept on nasal oxygen, and symptomatically she improved after 2 sessions of hemodialysis. Then suddenly on the 3rd post admission day, she had 2 episodes of sudden generalized abnormal body movements with uprolling of the eyeballs and frothing in the mouth and incontinence. There was no history of any trauma or tongue bite, and this lasted for 1 to 2 minutes, and it was relieved on intravenous medications. And she had 2-3 such episodes over the 2 days. She was taken to ICU in this time, and MRI brain was done. The report she is not aware of, and she tells that after these episodes, she was taken in a special form of hemodialysis, where she was given white bloods also. So 4 units blood she received in the 2 consecutive days, probably FFP. And she also remembers during this time she was started on BP medications also, and anti-seizure medications also. Now at present she is doing fine, and she is continuing on hemodialysis. History of past illness. I would like to report one event when in 2020, when she was discharged from Osmania Hospital. After 2 months of discharge, she complains of left upper limb reddish nodular swelling, skin lesions, which was reddish and very much painful and itching. There was a lot of itching. She consulted a private practitioner, and she was giving oral tablets. However, no further investigations was done. It healed gradually, and one lesion still has a scar in her left elbow. Otherwise, she had no history of any tuberculosis, any history of COVID, jaundice, hepatitis B, C, or any surgery in the past. Coming to the family history, she is a younger girl, and she has an elder brother, 23 years old. Her parents are separated. However, they have no comorbidities or any kidney disease in the family. Coming to the birth developmental history, she was born of a non-consanguineous marriage. There was normal vaginal delivery with no postnatal childhood complications. She has normal vaccination, normal scholastic performance, and she is COVID vaccinated. 2 doses she had received. Coming to the menstrual history, her onset of menarche was at 14 years, and she had regular menstruation, except, however, when in 2020, she did not receive her menstruation for 2 months. Following that, she tells that she has normal periods, and now also since 2 months, she is not having any menstruation. Coming to the personal history, appetite, sleep has been improved now. Urine output, she tells that it has improved following the hemodialysis process. However, she is not quantifying because she is on diaper post-convulsive episodes. And bowel is regular, no addiction history. Coming to the diet history, she is taking proper NIMS diet that is given. In the morning, she is taking 1 katori upma, and in lunch, it is dal, rice and curry. And in evening, tea, chai, biscuit, and dal, rice, curry in the evening. So in total, she is receiving around 1400 kilocalorie carbohydrate and around but less 12 to 15 grams of protein per day. Coming to the treatment history, now as she is receiving every medication as given in NIMS hospital. She is not taking any other medication from outside. She remembers name of the tablets of only MMF and BP medication and Caesar medication that she recalls. There is no allergy history, significant allergy history. So coming to the summary of this, to summarize, it is a 20 years old female patient presenting with fever on and off, generalized body swelling, oliguria and vomiting. She had similar such episodes 3 years back where she was admitted, renal biopsy was done, and she was advised for long-term renal follow-up. However, she defaulted on treatment. In between, she had one episode, and she had in between 2 episodes of cardiac problem, query myocarditis, and also one aphasia, probably some focal neurological CNS deficit or stroke. And at present, she has present of seizures, and also she is undergoing hemodialysis.
Dependent renal failure. So with this history, what is your differential diagnosis?
With this history, my syndromic diagnosis first is rapidly progressing renal failure, probably RPGN, and first cause immune complex mediated RPGN, that is lupus nephritis, considering the age of the patient and female with flare. And other etiological causes, I would like to keep other tubular interstitial causes also, which may precipitate or aggravate the event, like any ATIN or ATN, and also vascular causes also, like lupus vasculopathy or TMA. We have to rule out.
Rapidly progressive glomerulonephritis. She has got 3 years history of similar problem.
Yes,
so
sir.
do you still think it is a rapidly progressive glomerulonephritis?
Yes, sir. Actually, we can also give AKI on CKD, but in between 2 years, she completely stopped all nephro treatment, renal treatment. So now the history is over 2-3 months only, because she had one such discrete episode in 3 years back. In between, she had not taken any treatment. So, but if we consider as a spectrum,
to the present illness
yes,
and calling it RPGN, that is what.
Otherwise, if we see as a whole, we can also tell AKI on CKD, but there is no
Do you think this is two separate event or continuum of the same disease?
After the whole history, I believe it is a continuum of the same disease.
Yeah, obviously. You like to explain it
and
with
one
multi-system
diagnosis. Involvements also.
So then you cannot call it rapidly progressive glomerulonephritis.
Yeah, not
AKI. After this event,
actually you initially told 20 days of history, then I want to date back this shift
3 years back.
2020.
So you thought it's a continuous of the care. So what do you think? Is it any connective tissue disease you are thinking or what?
Given the female sex and the age of the patient, I would like to think as connective tissue disease, most probably systemic lupus erythematosus, now presenting with flare. It may be due to glomerular flare or also vascular any event.
What are the points in favor of diagnosis of a systemic lupus erythematosus here?
In this patient, female, madam, 20 years old, and
age
also
of the patient, sex of the patient, then
and also history of proteinuria in the 3 years back, and also the history that she underwent
renal disease consistent with a glomerular etiology, isn't it? Because of edema, etc., etc. Then-
Proteinuria, edema,
then
hypertension.
What else?
And also multi-system involvement, madam. She had episode of myocarditis and also CNS involvement twice in the form of stroke and seizures now.
Myocardial disease, cerebrovascular disease, and she had some joint pain,
She had also
etc.
arthralgia and also non-constitutional features like fever and weakness. She had since last 5 years also only.
Okay. Anything else in the treatment part for you
In
to
the treatment
suspect?
part, yes, madam, she already underwent biopsy and she was advised twice. She also had one eye examination at
She was
baseline
initiated on
and
mycophenolate mofetil,
mofetil
and second time advised
on pulse cyclophosphamide. It
once
seems
in
to be
2 weeks
pulse
injections.
cyclophosphamide.
So
Yes,
the
ma'am.
treatment that she received or advised is also
Also consistent.
consistent with the
Systemic
possible
lupus.
systemic lupus erythematosus,
Erythematosus.
isn't it?
Coming to examination now. Coming to the examination,
Also, she had
patient.
disproportionate anemia requiring multiple blood transfusion in between.
Madam,
This is
only
also
twice when
point
she.
in favor of
yes,
a
ma'am.
multi-system hematological involvement of
Yes.
possible lupus.
Yes, madam. And also cutaneous manifestation, only hair loss she had, but now at present she doesn't complain of any acceleration. Coming to the examination, patient was conscious but anxious, oriented, cooperated and appeared pale. BP was 160 by 90 mmHg in the left arm supine position. Pulse was 124 beats per minute, regular, normal volume, normal character, no delay and all peripheral pulses was palpable. Respiratory rate 28 breaths per minute. It was thoracoabdominal in type. Saturation was 98% at room air. In the weight was 52 kg, weight was 52, height was 156. Build is normal build. BMI was 21.4 kg per meter square. On general examination, pallor was present, pedal edema was present, pitting time reaching up to the mid calf region, and head to toe examination, there was alopecia is present, however it is non-scarring. And on general skin examination, she has one left upper arm, 2 into 2 centimeter blackish nodule is present, seems to be scar of previous any herpes infection likely. And also she in the abdominal examination, there was a linea alba is present in both sides. Coming to the systemic examination, she also has a
Any
right
active
sided.
arthritis at present?
No, madam, come in musculoskeletal examination, madam. There is no swelling or any tenderness in any of the joints present. But in respiratory system, she has
Any
bilateral
deformity
decreased-
for any joint?
no deformity present, madam. And
This is important?
yes, madam, it is important because generally in SLE we do not find deformity, but because it is more towards Jacob's arthritis in RA we can see, but in later stages we also can find deformities. And in respiratory system, she had decreased vascular breath sounds in both infrascapular area, and in cardiovascular she was very much tachycardic, but still ejection systolic murmur was present, madam. It was appreciated. And GI in gastrointestinal, she had mild ascites because flanks were full.
Any evidence of pericarditis, pericardial effusion?
As such, no evidence, madam. She was comfortably lying. Saturation was normal. No rub was
Important
present.
to look for?
No rub. Or,
Is it important to look for
yes,
pericardial
madam.
disease?
Yeah, because serositis is an active feature. And GI, no fluid thrill, but flanks were dull on percussion. Genital and examination normal. CNS examination was normal. Higher mental function normal. There is no cranial nerve examination was normal. No extraocular motor mobility deformity. Motor examination, bulk, tone, power, and DTR as normal. Plantar bilateral flexion and sensory examinations also normal. Musculoskeletal examination, no swelling or
What do
any
you think
redness.
the cause of her seizures that has happened recently?
Yes, madam. She says there may be multiple causes, madam. First, it may be due to lupus itself, causing a neuropsychiatric SLE, that is lupus inflammation. Second, it may be due to any infections, because she had also fever.
Received, she had
Third-
was on an immunosuppressants.
Yes, madam. Third,
Okay.
it is the drug induced.
Then?
Infections, madam. 3.
3.
4, maybe uremic, because she was also having uremic
On
symptoms,
dialysis. Can be
azotemia.
uremic seizures. 4.
No.
Fourth cause. She's hypertensive.
She is now recently
Can be
diagnosed
hypertensive and
Press
cephalopathy.
and hypertensive
Isn't it?
can occur.
All this can produce seizures in
Yes,
this
ma'am.
patient. Okay. How will you confirm that she has systemic lupus erythematosus now?
Now, at this point, initially,
What is the current diagnostic criteria for?
Current criteria is the ACR EULAR 2019 criteria, and it includes the first ANA, which is the entry diagnostic criteria, which is 1:80 in the HEP2 cell lines. If it is positive, then only we'll look for other additive criteria.
Okay.
And of them, there are 7
Can you
clinical and
diagnose
3.
SLE just by renal biopsy?
Yes, madam. Because it includes 10 points. The class 3 and class 4 proliferative SLE is 10 points.
Okay. ANA positivity with
plus
class 4 is sufficient for you to diagnose SLE.
Yes, ma'am.
Okay.
In what percentage of patients with lupus will you have only renal involvement at the onset of the disease?
Lupus can
No
have,
multi-system involvement.
only around 50% can have only renal involvement at onset. However, 60 to 80% can have in the progression.
50%?
No, you are
No,
Only
I get
renal
the
disease
question.
at diagnosis.
Means there is only renal involvement at the start of the disease, no other evidence of disease in any other domain.
You are
I don't
diagnosing
have-
SLE by kidney disease.
Yes, ma'am.
biopsy.
Kidney
Only
biopsy.
only biopsy, no other thing.
Present in
It's so
actually
common.
histology, it's common, sir. No,
Is it
only in
common?
clinical is not
Rough
that common. 30
percentage?
as clinically.
It's only 5%.
Okay, 5%.
It's only 5%.
Okay.
The question was directly biopsying the lupus
Okay, I
based on kidney biopsy.
Yes.
No other features were there.
Okay.
Overall SLE, what percentage of renal disease at presentation?
It is
Yeah.
around 40-50%.
That is what you are
That-
answering.
Yeah, maybe
I understood.
25-30%, maybe little more. Yeah.
During the course of the disease, what percentage of
Around
the
60 to 80%
up
will
to
develop.
80%
Yeah.
develop
And
renal
histologically,
involvement on
even-
follow-up?
Yes,
Yeah.
ma'am.
On follow-up.
If you do all three modalities, in light microscopy, immunofluorescence, electron microscopy, what percentage are likely to have renal
If we do
disease?
all, sir, it is told that around 100%, 90 to 100%
Yeah,
will have
90 to
histological
100%
evidence of
will
immune
have.
deposits in every patient.
Right.
What is the sex ratio?
It is told that, sir, females to male 9:1. It is told, sir, 8 to
Yeah,
9:1.
roughly. Except in children.
Children, yes.
Yes, it may not be that
Ratio
much.
And it is more
children?
equal. Madam, male are more, sir, madam.
Ratio male-female in children, female-male in children,
1:1, madam, 2:1, madam, so
4:1.
4:1.
Yeah, much less.
So in this patient, actually patient was undergone a biopsy and patient was kept on some steroid and everything. Do you think that this patient is a lupus?
This biopsy was done twice, sir. You were telling now this recent
No,
biopsy.
in the 2020 also.
In
there was a
2020.
biopsy.
Yes, sir.
They were given only steroid and MMR.
Yes, sir.
So if it is lupus, is it a lupus at that time?
Sir, history-wise, actually no documents were there, but history-wise,
Based on the
Treatment that she
protocol
received.
that the clinician started. You
it,
suspected lupus at that point of time?
yes, sir.
How?
Because she underwent renal biopsy also, and because no other features of ANCA
Based on
vessel
the
post
treatment
immune.
protocol the clinician used. Do you think that lupus is a possibility at that time?
Is that the accepted
Yes,
treatment protocol for initial treatment of SLE?
And they
Lupus.
accepted, actually, we expected that she would have given any pulse steroid and also IV cyclophosphamide. But since she was
For
a
a
young
20-year-old
child,
girl,
she's a young child, maybe she was given option and she preferred microphenolate mofetil.
so that is the accepted treatment for the initial treatment of SLE with lupus nephritis, isn't it?
Yes, yes.
When will you think of giving cyclophosphamide-based regimen?
When it is a severe lupus, madam, and it is crescents are there, and patient choice also, old patient already cost, because MMF is a costly drug, madam, non-affordability is there, then we can give cyclophosphamide.
Specifically only cyclophosphamide.
Specifically,
Crescent is there, and rapidly progressive, and also neurolupus and neuropsychiatric involvement are there.
Cardiac involvement, this patient also had a cardiac
She had
involvement.
after discharge, sir.
At that time cyclophosphamide was given.
No, because she remembers only giving tablets and cardiac tablets. She was told no injections were given.
In this age group, if you do want to use cyclophosphamide, how would you give it?
Yes, sir. In this age group, we first have to give consent to take consent of the patient.
That is fine.
Second, we have to we'll try to give shorter dose and shorter period of time, and we avoid giving cyclophosphamide during the ovulation time of the female patient. And also, if we have to give
pre-ovulation or
option,
post-ovulation?
we should not give in the peri-ovulation time, ma'am. And we should give them option of
Which half of the
cryopreservation.
menstrual cycle you recommend an IV pulse cyclophosphamide?
In the later half, madam. we'll
Second
give.
half of
Second
menstrual
half.
cycle.
And we should also give the option of cryopreservation of oocyte, and also monthly GnRH analogs like leuprolide can be given, and in male also we can give monthly hormonal injections.
And what will be the dose schedule? of cyclophosphamide?
In this patient, preferably because young, we should give 2 weekly 500 milligram 2 weekly for 6 doses.
Which is that
IV.
regimen?
That
It's
is
a ELNT regimen by Huso.
urolupus. Yeah.
Urolupus regimen.
Does age has any effect on the infertility in females?
Yes, sir. It is told that around a patient of
Cyclophosphamide
ELNT, yes, sir, in 20, around 50-60% had amenorrhea in 20 to 30 year age group, and it increases to 80% if the age is more than 30 years.
So the anger is better.
Yes, sir.
Yeah.
Do you want to screen her for antiphospholipid antibodies?
Yes, madam. According to SHARE guidelines, it is written that all patients should be of lupus should be screened for APLA at onset, and especially in
From
female
this
patients
history,
pre-pregnancy.
Do you think she has likely possibility of antiphospholipid antibody positivity?
Yes, madam, because she has CNS manifestation and it may be due to thrombus or stroke. Otherwise, she is unmarried and there is no other history of any swelling in the limbs or thrombosis or thrombophlebitis.
Cardiac disease
But,
also we do not know whether it is
yes,
myocarditis itself.
Yes, ma'am.
Maybe a coronary artery thrombus.
Yes, ma'am. So we
What
should
is the
check.
overall chance of APLA positivity in lupus?
In lupus, madam, it is around 30 to 40% get positive, madam.
To 50% of them
Yeah.
can have APLA positivity.
But you also said that patient is for some 2 weekly injection body.
Yes. Sir, I feel that when she presented with aphasia, sir, she was advised to have pulse methylprednisolone and IV cyclophosphamide, advice of 2 weekly injection for 6 doses, but she took only 2 doses. And
And what was the problem in expressing that this case of lupus nephritis? When sir asked you didn't tell that it is actually case of lupus nephritis. Your clinical diagnosis should be a lupus nephritis.
yes, sir, I told you, lupus with flare.
Presenting RPRF report.
Okay, sir.
RPRF is not the diagnosis.
Okay, sir.
The
Etiological
diagnosis
is
will be a
lupus, sir.
Lupus nephritis. Lupus.
Yes.
Systemic lupus erythematosus.
Yes, sir.
To
With
start
flare, huh.
Presenting problem is RPRF.
Okay, sir.
So, is she now in CKD 5?
Sir, after biopsy, clinically, sir, I
She's
don't
already
feel,
had 2 dialysis also, isn't it?
Yes, sir. Sir, clinically, I don't feel she may be CKD, sir. We have to see factors biopsy report also, because any precipitating, like any suppose pre-renal, any sepsis or any acute tubular injury or any vasculopathy can also cause this rapid deterioration. So
She did not receive any specific treatment till date.
Actually, she
Very
received
active
plasma. She's telling
lupus.
them.
Active lupus nephritis with a very high activity index and crescents can also produce with severe renal failure.
Yes, ma'am.
That is
So-
much more common than presenting with CKD in lupus, isn't
Yes,
it?
ma'am. Histologically, sir, it is over 3 years, so he is CKD only, sir.
Yeah, but is it end stage or not yet? That is the question, really.
That
We're
for
not
biopsy-
doubting CKD. Is it still in a
Yes, I
reversible
don't know.
stage or not?
I believe it is in reversible stage, ma'am, but I would like to confirm by biopsy and
But a biopsy done.
this time also done. The report she is not aware
Does
of.
the
What do you expect that histology is?
In this patient, madam, I expect 3 things. This sudden deterioration may be due to glomerular cause, tubular interstitial or
What is
vascular
likely
cause.
histology?
Likely histology in this patient, madam, I
Yes.
would like to expect crescents or any diffuse
Which class of
proliferation.
lupus nephritis?
Active with 3 or 4 stage
Ah.
of class
With-
of lupus.
Activity index and chronicity index?
With high activity and activity index will be high.
Ah.
For
And
this more than
chronicity?
12. Chronicity in this patient may be there, madam, around 12, madam, 6 by
Chronicity
12.
index of?
Total is 12, madam, around
For
low
this
low
patient?
chronicity.
Huh?
I would like to have high activity index, I'm expecting, and low chronicity index.
Some amount of chronicity also should
May
be
be there,
expected
because
the
3
disease
years,
is of
3 years.
3 years untreated.
Yes, ma'am.
Isn't it?
But I would also like to look for tubular interstitial causes, madam, and also vascular causes, because we cannot rule out TMA.
Tubular
and
interstitial disease is
vasculopathy.
also a part of renal lupus nephritis.
Yes,
Why should
madam.
you separately put a tubular interstitial disease as
No,
a
madam, madam. In
So that's a
glomerular,
part of
tubular,
lupus
vascular.
only, isn't
Yes,
it?
ma'am.
One of the marker for activity is the tubular interstitial
Yes,
inflammation.
ma'am. Yes, ma'am.
what happens to the clinical activity of the disease when the patient goes on to dialysis?
On ESRD, sir.
Yeah.
The clinic, the patients generally have less activity at that time, sir.
Yeah, it
When it's
becomes-
a burnt out disease,
Yeah,
will
it
decrease,
becomes
madam.
quiescent, isn't
It
it?
becomes
That
quiescent,
the
sir.
other systemic involvement generally disappears
It's
or
burnt out
regresses.
disease, yes, sir.
Yeah. So in this patient, it appears that that has not happened as yet.
Yes, sir.
She had seizures
Still activity
recently.
going on,
If
yes,
you
sir.
say that seizures are due to lupus itself and not due to uremia or hypertension or infection, then it means that the disease is still
Salvageable
active.
kidneys are there. We can
And
still say.
so maybe more likely to be salvageable. But of course, I'm not sure of that. Only the biopsy and the future follow-up will tell us whether that can be achieved or not. Besides MMF, cyclophosphamide, steroid, you've covered all that. Any other therapeutic regimens that have been used?
Yes, sir. In induction, if in induction or maintenance, sir, if without MMF and cyclophosphamide, we can also try multi-targeted therapy. It has been tried, and it is a combination of low dose tacrolimus, and also we can try rituximab. Though it is not still FDA approved, but rituximab has been tried. 1 gram 2 dose, day 0, day 14, and also as a new drugs have come like belimumab has come, which is also FDA approved, and it
Any
is
other
given
new drug
with
has
and
approved?
voclosporin,
Voclosporin.
and it is given with standard of care, not separately, but with we can add.
Yeah, but those two regimens are not applicable in India.
Yes, sir.
And even if they do come, they'll be very costly.
Yes, sir.
So really not practical in India.
Yes, sir.
In India, you have the other ones
Yes,
only that you have
multi-targeted.
to depend upon so far.
You said there is some special dialysis was given. What do you think it is?
Yes, sir. Actually, I think the patient was given plasmapheresis, sir, because she was replaced with FFP. And mostly, I think after seizures, she was diagnosed as neuropsychiatric SLE, and she was started on plasmapheresis.
What are the other indications for plasma exchange in lupus, other than cerebral lupus?
Yes, madam. It is severe diffuse alveolar hemorrhage also in hemorrhage, lupus, and severe serositis and severe pericarditis. APLA.
No, not in severe
APLA.
pericarditis.
Not pericarditis.
Actually, myocarditis. SLE can cause both, sir. But APLA also we can.
APLA,
give.
yes.
APLA.
APLA is
Cerebral
indication.
lupus, APLA,
TMA.
TMA,
Yes.
and plus minus in severe renal failure. That's all. What is a classical pathognomonic histopathological appearance to say that this is SLE?
The classical will be, madam, pleomorphic lesions. There will be,
Pathognomonic finding in the biopsy, light
that
microscope.
will be, madam, hematoxylin bodies, but it is only
How will you explain
present.
that? Can you describe that hematoxylin?
Yes, madam.
body?
It is a cell that is a chromatin. The denatured chromatin will be in the intranuclearly cell, and but it is only present in 10 to 20%.
But if present, it is pathognomonic.
Pathognomic of SLE. More commonly, madam, we see pleomorphic lesions. That is more specific.
There's a lot of controversy about one area in treatment, and that is the length of treatment.
Yes, sir.
So what do you say about that?
Sir, ideally we should continue maintenance therapy till at least 36 months, the KDIGO says, and 1 year should be quiescent. And however, there are controversies because we know that the histology does not correlate with the clinicopathology, because it has been shown that even if 50% of the patients who have no clinical activity can have histologic immune deposits, and the reverse vice versa is also true. So many centers undergo protocol biopsy, and I also think that we should have protocol biopsy can be done in before stopping of therapy, maintenance therapy.
And what will you look for in that biopsy?
Any
Protocol
evidence? Any evidence of activity, sir?
Activity index, yeah.
Activity
That's the
index.
most important. The
Yes, sir.
activity index should be 0 before you stop
of
therapy. That is one, at least one group feels that is how you should do it. And that is Brad Rovin's group. They have published on that. So they
Yes,
have been doing serial biopsies or sequential biopsies in those patients. So if the activity index is not yet 0, continue therapy, wait another 6 to 12 months, again do a biopsy. If the patient is maintaining clinical remission, see if the
Yes, sir.
activity index has become 0 and so on,
Yes, sir.
and then stop therapy. Still not continue therapy.
And they have shown that flares are also less if they
less.
follow this.
That's
protocol.
the That's the argument that they use, that reduced risk of flares and therefore reduced risk of CKD ultimately in
What are the
these
other
patients.
indications for rebiopsy other than protocol biopsy before stopping?
First will be for rebiopsy, madam, to see any TMA, madam, other causes, and
Rebiopsy,
also
indications
prognosticate,
for rebiopsy.
to
You have already
prognosticate the
biopsied,
patient also.
initiated on treatment. When will you think of doing a second biopsy?
When we are suspecting class change, madam, if the patient is having, and to decide on initiating treatment like induction or maintenance.
Already you had done a
Second-
biopsy. Nephrologists do start treatment only after a biopsy.
After biopsy,
yes,
yes.
And
Second
to,
biopsy.
When I am suspecting class change,
Okay.
or when I am suspecting other causes like, madam, lupus podocytopathy or vasculopathy.
Yeah,
other.
or if you think it
Third,
is just
prognosticate-
progression
Huh,
versus a transformation or a flare,
Yes, sir.
that is an
Normal
indication for
Any
a
other
biopsy.
indication?
And to prognosticate the patient also, madam.
That
And,
is first biopsy. Second biopsy. Patient in clinical remission, serological remission, proteinuria is persisting. What is your opinion? No sediments, normal RFT or serologically also in remission. But proteinuria is 2 plus more than 1 gram.
yes, madam. Any podocytopathy and also will
Is
be
it
there.
podocytopathy here?
Or मतलब chronicity is there, मतलब CKD.
Whether you have to
progressed.
intensify immunosuppression or
Chronicity, yeah.
set a part of that is another.
Yes, ma'am.
Then resistant lupus.
Yes,
At the
ma'am,
end of 6
resistant.
months, resistant to your treatment, you have to do a kidney biopsy. These are the
Yes,
4 indications for rebiopsy on follow-up.
Yes, ma'am.
What is the Win lupus study? Again related to the length of therapy that I was asking,
Okay, sir.
maintenance therapy.
I am not aware of, sir. I'll read.
Well, there were, you can read it up in detail. There were 2 groups. In one group, they discontinued therapy after 2 to 3 years. As you said, 3 years of therapy with the maintenance therapy. And in the other group, they continued therapy and looked for relapses.
Okay.
So, and they found that relapses were greater in the group in whom therapy was discontinued. However, a significant number in those in whom therapy was discontinued also did not relapse. So the problem is in identifying who is going to relapse and who is not going to relapse. Right? So that doubt still remains. So there is one group who says do a biopsy and decide, but there is another group which says, look, I discontinued therapy and yet so many patients didn't relapse. So why the need for a biopsy? But I think you should read up this in detail.
This patient is married and want to become pregnant. What will be your advice on pregnancy?
Firstly, I would have to explain. There will be preconception advices first should be
Okay.
there, that a patient should be 6 months quiescent, disease quiescent, no activity clinically.
Patient should have
Second,
completed the initial 6 months of
initial,
treatment. Isn't it?
And also 6 months there should not be any activity clinically. Second, patients having creatinine more than 2 are discouraged to have pregnancy. However, and then after we should change the therapy of the drug of the patients. We should change to non-teratogenic drugs. Like if patient is on MMF, we should change to azathioprine. Ideally, at least minimum 3 months before conception.
Okay.
And now, if the patient has now conceived, now I would like to monitor her more regularly for proteinuria, BP, hypertension,
Any other
and
drugs to be
creatinine.
added once she
Yes,
become
madam.
pregnant?
Yes, aspirin should be added at least 16 weeks as per the Aspire trial, and we should also continue SHCQ because hydroxychloroquine it has shown to decrease flares and decrease thrombotic episodes in pregnancy, and also
Do
we
you want
should
to
undergo.
prophylactically step up immunosuppression once she become pregnant?
No, madam, not stepping up. We should continue as it is, and we should also check for anti-Ro and anti-La antibodies of all pregnant patients. Because of the fear of congenital heart block, madam, we should look for.
Incidence of
It is
congenital heart
incident
block?
low, madam, 2% only.
1% only.
1 to 2%, and but if there is past history of fetal
How
with
will you
heart block, it
differentiate
increases.
an activity of the disease during pregnancy versus preeclampsia? She is a high risk of developing preeclampsia also, isn't it?
Yes,
So how will you differentiate?
In the preeclampsia, madam, there will be first, as per the definition of preeclampsia, there will be hypertension 140/90 after 20 weeks of
Relapse
pregnancy.
also, flare of the disease also
Can
occurs
occur
in the
at
third
any time.
trimester and
Yes,
postpartum.
In preeclampsia, madam, there will be typical premonitory signs of abdominal pain, headache, vomiting will be there, which may not be in lupus flare. And also by a new technique is SFLT and PIGF ratio. It will be increased in preeclampsia.
Any other
That
simple
is-
urine test will differentiate?
Yes, madam.
Active
Active
urine
sediments
sediments.
are more towards,
Active
yeah.
urine sediments, if present, is in favor
Flare
of a
Flare.
lupus
Lupus
flare,
flare.
isn't it? Hypertension, proteinuria, was everything will happen in both.
Yes, yes.
And according as you said, SFLT,
It's a new-
placental growth factor ratio also will
Increase in
in favor of
preeclampsia.
preeclampsia.
Can you tell about the remission rates with different regimens, the ELNT protocol, NIH protocol, MMBS protocol? In this patient, actually, you see, they tried with ELNT, relapse.
Actually, she was,
Ultimately, they tried with plasmapheresis. Nothing is going to work in this patient. Right?
Actually, she also was non-compliant, sir. So it's difficult because 2 years she left. Yes, sir. She may be a resistant case also, sir. And
Whether
one
our
different.
induction regimen at initially was right or wrong.
Yes,
Can
sir.
you tell us more about the remission rates with each protocol?
Sir,
Each protocol.
each protocol in NIH protocol that we follow, sir, that is the last third gold list protocol, that is cytotoxic plus methylprednisolone. The remission rate is good. It is around 94 to 96% remission rate induction. Around 90%, sir, they saw remission rate, complete remission. And in Illuminated.
Showing the remission rates just for 90 to 96%.
Sir, actually the NIH 3 trials, sir, that generally initially.
You want NIH trial? Any Indian trials are there where they tried the NIH and other regimens and they showed this?
Indians are
percentage
from
difference?
this much, I am not sure, sir. But in Chandigarh they did one study with MMF versus IV cyclophosphamide. They showed that both has equal efficacy.
How much
And
percentage?
it was it will be around 80-85, sir. It has pretty good response rate, we see.
Then why did you
generally.
offer pretty good response to this lady?
Yes, sir. Actually the reports were not there, and we are not sure that. Yes, sir.
The way you counsel the patient also important.
Yes, sir.
You don't, how many percentage of the women will go into ovarian failure because of NIH?
Less, sir.
Then what is the reason? Why we are not offering the best therapy for this young lady? Because this young lady, they have more active disease.
Yes, sir. And it is cheaper also, so they are compliant also more. But this case, I'm not aware of that, why she was started on
Given option,
MMF.
you give NIH regimen for this lady?
Yes, sir. NIH or ELNT, sir. I prefer ELNT, but NIH can also be
ELNT,
given
how
in
much
rapid.
remission rates are there?
What was the fallacy of ELNT?
It was only severe lupus cases, less severe lupus cases
Yeah,
were
less
taken,
severe.
and
They
for
were
patients,
excluded.
severe were excluded.
Still gold standard remains NIH.
NIH, sir. Yeah.
What is the recent modification of the therapeutic regimen that has taken place? The induction and maintenance therapeutic regimen. Is there any change in that has recently been advocated
In
with
terms
regard
of,
to steroids? I'll ask you specifically.
Yes, sir. Previously, we used to follow high-dose steroid, but now
Yeah.
KDIGO 2021 says that we can also give induction with a 0.5 to 1 0.5 to 1 gram IV steroid, and maintenance, and then followed by 0.6 to 1 mg per kg per day oral steroid, and it can be tapered also over 3 months.
What should be the
Matlab,
maintenance dose of steroids as per KDIGO?
As per KDIGO, madam, 0.6 to 1 mg
5
per
milligram
kg.
daily.
5
That is
5
milligram
sufficient.
milligram daily is, yeah.
tapered
So,
over 3 months.
sufficient.
so overall
The
lesser
steroid burden has decreased.
steroid, both the initial methylprednisolone and the oral prednisolone,
So steroid burden has decreased to
much
improve the
less,
quality of life of the
roughly
patients.
50% of what it
Yes.
was, and more rapid tapering also.
Yes,
That's
For
the main
maintenance,
change.
they recommend MMF itself.
yes.
Yeah.
Only
Now is the
if
first choice.
ASA is in patient can't afford or
pregnant
can't tolerate
yes,
MMF.
then as
ASA,
or in
otherwise
pregnancy,
MMF is
otherwise
the-
MMF.
So what is the chance of this patient going to get better?
Sir, at this stage
How
we
many
can
lupus there would be,
prognose.
compared to diabetes or compared to ADPKD?
If therapy now with recent therapies are very less, around 10 to 20% only can go to ESRD. Previously without therapy there used to be more, 60-70%. So this patient, I still believe that if she is compliant,
They used to die with infections and other complications.
both sir,
In your
infection.
dialysis unit, you see more lupus cases are there.
No sir, no. Because
What is
now
happening
it's
to
very
them?
effective because they mostly they are not going to ESRD and we can manage before going. They are living normal life sir with pregnancy and all. They have a good quality of life nowadays with good therapy.
So
Yeah,
for a
but-
transplant, what are the
Yes, sir.
precautions that you take if she wants to go for transplant? She attend ESRD, then how do you prepare
Yeah.
her for transplant?
Transplant also ideally we should she should be disease free for at least 1 year, and we should also check APLA positively for every patient because high risk of thrombosis, renal vein thrombosis there, and
And DDS-DNA?
all serology would be negative, madam. DSDNA or ANA should be quiescent, and however we can go ahead with transplant, and the relapse rates are also less. So
How much
that's what we
roughly?
should- It is 1 to 5 around 1 to 10%, sir.
10%. Up to 10%.
Up to 10%.
Yeah, that's it. I think we finished.
What are the risk factors for relapse?
Risk factors for relapse.
Yeah, after transplant, sir. There may be if patient present with in less matlab young age of end-stage renal disease and use of steroid-free regimen in past, or hypertension and young onset of ESRD, sir.
Active
Yeah,
disease
yeah.
at transplant.
Active disease at transplant. That is not done, ma'am.
Female, young age.
Female, young age.
2. Dialysis,
Active.
dialysis has a role in that. What type of dialysis you use? Is it more common in those people who had a transplant with this hemodialysis or with CAPD?
And read, sir.
Is the activity in end-stage lupus patients, is the activity more on hemodialysis patients or CAPD patients? Lupus activity. You still have some lupus activity, even burnt out cases. So is it more with hemodialysis or more with the CAPD? Lupus activity.
More with CAPD surgeons, sir.
How?
And read, sir.
Okay, you are right. It's more with CAPD. So patients who are on CAPD, when they go for transplantation, they are more likely to have a
Relax.
recurrence. Okay. And it depends upon the activity. If they are totally burnt out, then they may not recur. If there is still some activity is still there, they are likely to recurrence is likely. Okay. So,
Thank you, sir.